This is Dr. Michelle Cotty, and today we're going to talk about medications for substance use disorders. So this is a brief introduction. The objectives for this lecture are that by the end of it, you'll be able to identify the medications used to treat psychotic disorders. The goal is to memorize the drugs in each category and be able to summarize the adverse effects of each medication. Alcohol withdrawal usually starts within 4 to 12 hours of the last drink of alcohol, and it can last 5 to 7 days. These patients may experience symptoms including nausea, vomiting, tremors, restlessness, inability to sleep, depressed or irritable mood, increased heart rate, blood pressure, respiratory rate and temperature, diaphoresis, tonic-clonic seizures, and illusions. They might feel like bugs are crawling on them. So they can experience something called alcohol withdrawal delirium, and that can occur 2 to 3 days after they stop drinking alcohol. This is considered a medical emergency. So they may have severe disorientation, hallucinations, severe hypertension, and cardiac dysrhythmias. This type of withdrawal can progress to death. So part of our job as psychiatric nurses is to make sure that doesn't happen. We'll talk about how we do that coming up. For opioids, withdrawal manifestations can occur within hours to several days after cessation of opioid use. Common findings include agitation, insomnia, flu-like manifestations, rhinorrhea, yawning, sweating, and diarrhea. Withdrawal manifestations are not life-threatening, but suicidal ideation can occur. And when individuals stop using tobacco or nicotine, they become irritable, nervous, restless. They may have difficulty sleeping and concentrating. So there are other substances that are associated with substance use disorder, but again, this is just an introduction to medications that we use for substance use disorders. When an individual is experiencing alcohol withdrawal, we often use benzodiazepines. So these include Librium, Valium, Ativan, or Serax. A lot of places use Ativan inpatient. And the intended effect of these medications is to keep the vital signs within normal ranges, decrease the risk of seizures, and decrease the intensity of withdrawal manifestations. So we would want to administer these as needed and obtain baseline vital signs, monitor the vital signs and neurological status on an ongoing basis, and provide for seizure precautions. We also may need other adjunct medication, and those are listed to the right. So carbamazepine or Tegretol decreases seizures, clonidine decreases vitals, propranolol decreases vitals and cravings, and atenolol can also decrease vitals and cravings. Again, implement seizure precautions, monitor those vital signs, and check the heart rate prior to administering propranolol. Hold it if it's less than 60 beats per minute. There are medications available for abstinence maintenance. So this would be following withdrawal. Disulfiram or antabuse is aversion therapy, so it's behavioral therapy. If you're taking this medication and you drink alcohol, you can experience nausea, vomiting, weakness, sweating, palpitations, and hypotension. It can progress to respiratory depression, cardiac suppression, seizures, and death. When the patient drinks any alcohol, this is potentially dangerous. So this means the individual can't have cough syrup, aftershave, mouthwash, hand sanitizer. They may want to wear a medical alert bracelet. And we also would encourage them to be in some sort of self-help program like AA. We would want to monitor for severe side effects for up to 2 weeks after the discontinuation of antabuse. So this works through aversion, or behavioral therapy. Naltrexone is a pure opioid antagonist that suppresses the craving and pleasurable effects of alcohol. And we can also use this one for opioid withdrawal. So we're going to assess the client's history to determine whether the client is also dependent on opioids, because using that increases the risk for opioid toxicity if the individual is taking opioids at the same time. We're going to suggest that they get the monthly IM injections of naltrexone, which are the Withdrawal injections. And we'd encourage them to take it with meals to decrease GI distress. And finally, we have a camprosate or Camprol, and that's taken 3 times a day to reduce the unpleasant effects of abstinence, such as dysphoria, anxiety, and restlessness. These individuals may experience diarrhea, so make sure they're getting adequate fluid intake, and avoid using this medication if pregnant. Medications for abstinence maintenance for opioids. Methadone is an oral opioid agonist. It replaces the opioid that the patient is dependent on, and it removes the need for the illegal opioid by replacing it to the legal drug. This is a long-term maintenance medication, and it must be administered from an approved treatment center. Client should also be in some sort of therapy or counseling program or a 12-step program. Clonidine helps with withdrawal effects from opioids. It's related to, it helps with the withdrawal effects that are related to the autonomic hyperactivity. So these side effects would look like diarrhea, nausea, or vomiting. So when an individual is withdrawing from opioids and they're experiencing diarrhea, nausea, vomiting, then clonidine helps reduce those withdrawal effects. The side effects of clonidine include drowsiness or dry mouth. Finally, buprenorphine is an antagonist opioid used for both withdrawal and maintenance. It decreases feelings of craving and can be effective in maintenance compliance. So these come in sublingual tablets, a film, and a surgical skin implant. And a primary care provider can prescribe and dispense these. So that's different than methadone. Most people take it sublingually. Sublingual. So individuals who are prone to opioid overdose should be prescribed the antidote, which is naloxone. It's an opioid antagonist that can reverse respiratory depression, coma, or other effects of opioid toxicity. We also have flumazenil, and that's a competitive benzodiazepine receptor antagonist that's given IV, and it can reverse sedative effects and toxicity as well. For individuals who are trying to stop smoking, there are a number of products to help. So bupropion or Wellbutrin helps decrease nicotine craving and manifestations of withdrawal. We would want to advise the individuals to avoid caffeine or other CNS stimulants to control insomnia and to take this medication in the morning. Nicotine replacement therapy comes in a variety of ways. So nicotine gum, nicotine patch, nicotine nasal spray, lozenges, inhalers, and it's a substitute. So the rate of tobacco use cessation is nearly doubled. So people are twice as successful when they use these nicotine replacements. 1-800-QUIT-NOW is a free resource that you can give your patients. And they also have nicotine cessation counselors. I believe that they send the replacement therapy, like the gum or the patch, for free also to the individuals. The nasal spray provides pleasurable effects of smoking because it's a rapid rise of the nicotine level in the client's bloodstream. So one spray in each nostril equals the same amount of the nicotine in one cigarette. Individuals who had upper respiratory system issues like sinus problems, allergies, or asthma would not be good candidates for that type of nicotine replacement therapy. We want to avoid the use of nicotine inhalers in clients with asthma, and we always want to taper these over a period of time, because remember, small changes are more effective over time. So you have more effective habit change when we decrease the amount of nicotine, say over 3 months or 6 months. Use of nicotine gum is not recommended for longer than 6 months. For nicotine gum, you want to chew it slowly and intermittently for like 30 minutes, and then don't eat or drink 15 minutes prior. For a nicotine patch, you want to apply the patch to an area of clean, dry skin each day. In general, the patches are applied in the morning and they're removed 16 hours later. You do not want to sleep in them because they can cause nightmares or sleep disturbances. When you're wearing the patch, you should not be using any other nicotine products. And of course, a side effect from a patch could include a rash. We also want to remove the nicotine patch prior to an MRI. For the lozenges, avoid oral intake 15 minutes prior, so no eating or drinking before 15 minutes before the lozenge, and allow it to slowly dissolve in the mouth for 20 or 30 minutes. You don't want to use more than 5 in a 6-hour period and no more than 20 a day. Finally, we have Chantix. So this is a nicotinic receptor agonist that promotes the release of dopamine to simulate the pleasurable effects of nicotine. It reduces cravings for nicotine and therefore reduces the severity of nicotine withdrawal. It reduces the incidence of relapse because it blocks the desired effects of nicotine. So as a nurse, you want to monitor blood pressure. Individuals who are diabetic can have loss of glycemic control. Follow the instructions for titration on the medication, and that helps with the adverse effects. It can cause some neuropsychiatric issues like unpredictable behavior, mood changes, suicidal thoughts. If an individual drives a commercial truck or bus or is an air traffic controller, an airplane pilot, they cannot use this medication due to the risk of unpredictable behavior. If nausea, vomiting, insomnia, new depression, or suicidal thoughts occur, of course, they should notify the provider. And we want to discourage the use of e-cigarettes. Their dose of nicotine is unpredictable, data on safety and efficacy are lacking, and they're harder to stop using. And that is the conclusion for our introduction to medications for substance use disorders.